Right? I don't know, I just got real
All right. Hi, everyone. I am really excited to be here today. I'm Dr. Megan Sandel. I work at Boston Medical Center. I will say, as a pediatrician who has been really interested in how housing impacts health for, I will say, 20 years. I'd like to think I don't look that old, but yes, when I was a toddler, I was really interested in housing. And so I first like to know my audience a little bit. So the first kind of semi-strange question is, how many people have heard me speak before? All right, so I got about a third of the room. Okay, good. And then I'm hoping I'll say new things for you, and then the other 2/3 of you, I hope you'll like what I'm saying. And then just to, because I'm so happy to be here with really great friends, Gail, Livingston, and Kane, we're going to moderate ourselves. And so we are going to give you a little bit of an overview. I hope we'll only talk for the three of us for about 25 minutes, which will allow a lot of time for questions, because we really want it to be a back and forth. So I'm going to give you a little bit of the healthcare perspective. I'm going to give you orientation to what I call the $3 in the healthcare system that are potentially available for housing and health partnerships. I'm going to briefly describe how Boston Medical Center is currently funding a housing initiative where we're trying to do very specific types of housing partnerships, including deepening our partnership with Boston Housing Authority, and just reflect on how I really view Boston Housing Authority as a premier housing partner, why that has been such a really important part, and how the lessons learned from Boston Housing Authority can be carried over to other housing authorities. And then I think Gail will give her perspective around their experience working with public health and healthcare, and then John will give you the very nitty-gritty kind of like, these are the types of partnerships, these are the lessons learned. And so one of the things that I have tried to do as I've tried to think about housing partnerships is to think about where the money is, right? And so I sometimes will say we as healthcare are the big dog. We are the rich uncle. We are a sixth of the economy, right? And so we are a really important industry, but I think it's sometimes hard from the outside to understand the different funding streams. And so I tend to talk about them as 3 different dollar sets. So one is called community benefit. How many people here have heard the term community benefit? All right, a fair number. How many people feel like they understand community benefit? All right, slightly lower number.
Yeah, slightly lower.
So the way I think of community benefit is there is a obligation under the IRS that nonprofit healthcare systems meet what would be their tax burden if they were for profit to do a certain amount of community benefit. They report that, so that's publicly available information. You can look on the 990 forms of any healthcare institution and see what they're writing down. A lot of people think that started under the ACA, but it didn't. It just got a little more clarified under the ACA. And one of the things that a lot of health systems would do previously was write off their charity care as their community benefit. And now that more people are covered, there's potentially newer dollars they need to think about ways to allocate. I think that for the most part, it still is a pretty opaque system to understand of what's a community benefit dollar, how are they using it, but that is a functional dollar in the system. It's not a tiny dollar, it's about $50 billion a year of documented community benefit spending. There is some sense that a housing health partnership could count towards community benefit, but it's not a huge dollar, right? So I think everyone thinks it's this big, huge dollar and people are going to write huge numbers of checks. I will just say, when I talk about our housing initiative, I'll talk about a specific type of community benefit dollar that we were able to tap into. The other dollar is what I call a provider or payer dollar. Sometimes people are calling it like an accountable care organization or ACO dollar. And the reason that's important is that healthcare used to get paid on a volume basis. So it used to be that you had somebody who was really sick, They called 911, they came to your ED, they got hospitalized, they went back home. 2 or 3 weeks later, they got sick, they called 911, they came back to our hospital. Every single time that happened, we got paid. Like, there was not a ton of incentive, frankly, to make that person healthier. Now the thought is that it sometimes will be called value-based payment. And the reason that becomes important is that now we are functionally getting a set amount of dollars for that person. So if they keep coming back and forth, after a while, we're not getting paid any longer. There's no longer a kind of financial, there's a real problem with the fact that they're utilizing a lot of healthcare. And just realize that within the healthcare system, there is a small pool of patients, some people call it 5% of the patients, that use 50% of the dollars, right? So if we're trying to decrease spending, we're trying to live within a budget, trying to stay profitable, it becomes super important for us to look at that 5%. Some people call them high cost, high need patients. Just for context, at Boston Medical Center, when we looked at our top 3% that use 40% of the dollars. When we looked at those top 3%, 40% of them were homeless. And so you can imagine, you can do the best case management system you want. If you can't find them, if you can't send services and other things to help keep them healthier, you're just not going to be as effective. I will say within those dollars, there's kind of provider dollars and payer dollars. So Medicaid and Medicare are not the same thing. Medicare is for elderly and disabled. Medicaid is for low income. Sometimes people have both. Sometimes people have one or the other. But there are going to be, I think, more and more these ideas of either payer funding streams and or these kind of payer provider funding streams when you're kind of marrying that together into what's called accountable care. The third dollar is this idea that many hospitals and health insurance plans have capital reserves. They have investment portfolios. And they typically invest right now without a lot of thought towards investing in housing and using their investment portfolio for social impact. And so that there are some really amazing visionary organizations that have started to do that. Many of them, not coincidentally, are Catholic healthcare systems that have been motivated much more by mission than necessarily the margin of what they're making, but they're laying the groundwork for all of us to follow around how to do that. So just think about it, there's a community benefit dollar, there's kind of like a payer provider dollar, and there's an investment portfolio dollar. So we at Boston Medical Center, because we are now entering into a lot of these value-based payments and somewhat consistent really with our mission as the safety net hospital in Boston, embarked on a housing initiative that was funded out of a type of community benefit obligation called determination of need. And what that means, in a lot of states, it's also known as certificate of need. About 34 states have this program, where when we as healthcare build a new tower, you'll charge a percentage of the project in order to get your certificate that you can actually open the building. You need to do a community health initiative to actually improve the health of the community based on either a community need or a determination of need, right? So we at Boston Medical Center, consolidating our campus, we're building a new tower. We had a $6.5 million obligation under the determination of need program. And so we went to the Department of Public Health that kind of mandates this program and manages it and said, listen, we think the biggest community need for our patients is affordable housing. We want to put all of the money into an affordable housing initiative. Is that okay? And they said yes. So I think the good news is that in all of your communities, affordable housing is a big community health need. So that's not going to be, I think, a huge heavy lift. We then went into it thinking about we wanted to invest in different types of partnerships. So we didn't want to put all of it into one project. We wanted to maximize our learning. And so we did 2 project-based investments, 2 resident service collaborations investments, 2 what I call hybrids, where it's some kind of capital type of improvements and resident service collaborations. We're doing a huge community engagement initiative, and we are investing in an equity fund. So we are investing in the Healthy Neighborhood Equity Fund that was put together by Conservation Law Foundation, Mass Housing Investment Corporation, as a model for us to then potentially use some of our future investment dollars in the future. Okay? I am going to stop there. I can talk a long time, and I'm going to hand it over to Gail to just talk a little bit more. Just in the last 30 seconds, I just want to compliment Boston Housing Authority. I give a lot of talks around the country, and I talk about how great it is to work in with our public housing authority, and there sometimes is some skepticism about whether housing authorities can be great partners. And I know you guys know you are great partners, but I just want you to know that I really view the experience that we have had as a way for you to open doors and say this can work. This is how things can work, because I would say we wouldn't be, it wouldn't have been as possible for us to do this housing initiative without our experience working with BHA. Thanks.
Okay, well, thank you very much. My name's Gail Livingston. I work for the Boston Housing Authority. My title is
I was the Deputy Administrator
for our housing programs. And that just means that I oversee the public housing portfolio, the leased housing portfolio, and our admissions and occupancy screening department. So I try to keep a hand in all of this stuff. And because it's a lot of what keeps the job interesting is to try and build what we do. And so, you know, when I looked at the title of this session, and it's investments in housing, and investment's a big word. It can mean all kinds of things. It doesn't have to mean new apartments, although I'm glad to hear that maybe it's going to. That's to be nice. But investments are also training for staff, providing supportive services, community health workers, and it's sort of an expression of who we are, because we invest our time and our energy in things that we recognize as important to our mission. So I'm going to tell one really short Megan story. And I think I remember this correctly because it goes back a lot of years. So Megan, as she said, has been working at the intersection of housing and healthcare for a lot of years. And well over a decade ago, probably maybe even 15 years ago, I first got to know Megan. And my first memories were she was really a strong, strong advocate for her young patients who had asthma. And she was very frustrated with the BHA and our inability to respond in what she felt was a timely way to working on the problems that were having an adverse impact on their health. And so what did she do with that frustration? Well, she came and talked to us. And she actually sat in our transfer review committee and spent time and sort of saw what we were up against, trying to understand what was going on with the housing authority. Were the housing authority just bad people, or were there things in the system that were making it hard for them to respond in a way that she thought was useful? And then we got to understand what was really important from talking to her as well. And out of that came improvements to our reasonable accommodation transfer. She helped us rewrite questionnaires and all of that kind of stuff. So that's Megan's investment. That's how she started her investment in healthy housing, and that's how relationships get built. So from the housing authority perspective, and in Boston, we take our responsibility for stewardship of this super scarce resource that we have, this deeply affordable housing. We take that really seriously. They're not making much more of it. So I'm going to go off script for a second. We were talking. I was listening this morning. This morning was just amazing, listening to everybody talk and all of the things that we need to do to end homelessness and work with homeless people. And one of my big frustrations over the past few years is as we get better and better at collaborating, we learn how to do that because that's a skill by itself. And as we grow more and more partnerships, and we begin to realize all the things that we could do to really help this very vulnerable population that we're here to serve. And we reach out and the resource just isn't there. It's a shrinking resource at this time. And so I would just say to all of us, as we build these partnerships, let's build partnerships with Strong and other organizations, because together maybe we work, that helps us work to lobby for greater investments in deeply affordable housing, because, there just isn't enough of it, and so we need to keep that in the back of our minds. We need to use what we have in the very best way we can and to be thoughtful about it, but we really do need more of it. So we work really hard at just trying to keep what we have running successfully. At the Boston Housing Authority, we have set our homeless families and individuals are our number one priority for applicants. So we are housing a number of those people at the top of the cost sector for Boston housing. And we take very seriously not only the need to house them, but to keep them housed successfully, because that is not easy, and that's what we need the partnerships for. So we always value the assistance of people that come from different areas of expertise. It makes us better at our jobs. But now, with diminishing resources, we need those partnerships even more. And the healthcare industry, because they're the big dog with the pots of money, they're uniquely situated to support our residents in ways that we can't. So we try to work from a platform that housing provides to reach a community that otherwise would go underserved, and to use our partners to help with. So for PHAs, I came up with this kind of laundry list of things that I think that you can think about doing and that we have thought about doing and done. So, and some of this is repetitious because other people in other panels that I've sat through have said some of the same things, but that doesn't mean it's boring so much as that everybody's thinking about it. Get to know the providers and everybody who's working in your community. At one point, I know I had staff people say to me, Gail, why are you on the board of the Asthma Regional Council? What does that have to do with your job as the Director of Operations, which is my title at the time, at the Boston Housing Authority? I'm like, well, you get to meet new people that way. You get to meet people that you wouldn't ordinarily have met, and maybe understand what their work is and forge some connections. So yeah, it took time, probably that I should have been looking at occupancy numbers or something, but I have wonderful staff, so they can do that. But I think it was really important. It's really important to do that kind of thing. Sit down with anybody you can, especially your critics. I like to be at a table with people who are skeptical of me and my organization, because A, they get to know me, and I'm so charming that, not really, but I'm actually not at all. But it's always harder to be mad at, it's harder to be angry at people that you actually know if you can call them up and speak with them. So it's really useful. Sit down with people who might be your natural enemies. Start small. Accept any level of partnership that you can get. If anybody's willing to work with you on even a small thing, work on it, because you get some small successes, and that builds the relationship as well as everything else. And then you can build on that, and so be lining up ideas in your head of the next thing that you could ask this group or organization to do while you're doing that. Now, this one is, I think, really, really important. Don't forget about your staff. Work with your staff, the site level staff especially, to make sure they understand why you're doing what you're doing. Why am I bringing in all these chronically homeless elders? We have a program now, a special supported housing program, working with the city, coming off the chronically homeless list, chronically homeless elders. These are not easy people to house necessarily, but you need to prepare your site staff, because they're the folks that are going to be having to keep these people in successful occupancy and working with the service providers and doing all that. Make sure you bring them along. With smoke-free housing, we did that a lot. We had our staff come up with the procedures that we would use for enforcement. We talked with them. We're fortunate we have lots of academics in the Boston area. We had people come in and talk about secondhand smoke and the problems of smoking. So, invest in invest in your staff as well, and make sure that they kind of understand what you're doing and how it works in with the mission, and make them part of the mission. It's real important, because otherwise they're just they feel like they're stuck on the receiving end of making their work more difficult. Get your residents involved. Your program will be better. You'll understand better what's really needed. You'll understand what people will take advantage of, which is kind of important if you're going to put a program in that people actually want to participate. And they can be great political friends if they are, if they really like what you're doing. So that's especially true of the elderly and disabled populations. Everybody loves them, and and so but it also it makes your programs much better if you can do that kind of thing. Also, and this is really hard in these days of terrible budgets. Establish some kind of internal capacity to manage these programs and to keep an eye on the partnerships. Everybody can't just be doing it off the edge of their desk and have it be pushed aside by the latest, as a colleague of mine calls, fire drill of the day. It's just, it's really hard, and it may be really hard to make the case to your executive director or to your board or to whomever, but try to establish some kind of designated, dedicated capacity to manage some of these partnerships. Otherwise, it's just going to be very hard for you to be responsive to your partners and to really keep them going in a meaningful way. Also, having these partnerships includes your chances, I think, of getting funding through. I know the funders will be doing a roundtable later this afternoon, but we found being part of parts of collaborations with our Public Health Commission, with BMC, with various universities, has enabled us to bring in funds that help do a lot of these housing and supportive services relationships. And also then you've got a structure in place when funding opportunities may just sort of drift over the transom, and you say, ooh, well, I know who I can work with on that. You don't have to sit down and say, gee, this would be great to do if only I could find a partner. Well, you've got a bunch, and you can approach them. So that's all I'm going to say for now. I hope we can talk about specific programs later. And my colleague, John Kane, who will introduce himself, but he is the person at the Housing Authority who keeps all these things going, in addition to doing a bunch of other things too. But without John,
No, it's totally true.
yeah, without John, it wouldn't happen. So, John.
All right. Good afternoon. So my name is John Kane. I also work for the Boston Housing Authority. And I want to thank CLPHA for the invitation for this panel and just for this whole topic of health and housing. And I think that it's been a very strong response. And so there's good timing here. There is an appreciation for this intersection of health and housing. Where you live has a big impact on your health. And I'm going to kind of take my remarks down to, as opposed to the 30,000-foot level, to the 3-foot level, and just talk about a few different specific examples over the years that we have partnered. The Boston Housing Authority has partnered with the Boston Medical Center. And I'm not sure that any of these are, groundbreaking or completely original. But I think that overall they give some examples of how housing authorities and hospitals, which are anchor institutions, which are everywhere in large and small communities, that they can work together. And I'm also, cognizant that there's a lot of expertise that's here in the room, and so I'm not the only expert. A lot of other people have a lot of other experiences to offer as well. So many years ago, Megan was trying to, there was a thought that if somebody came into the emergency room and they had asthma, that you wanted to be able to write them a prescription so that they could have a pest-free home. And the truth was that they couldn't necessarily come back to their BHA apartment after they'd been to the emergency room and gotten all the medical care that they needed. Then they were going to come home and be in this apartment where there were unhealthy housing conditions. And so there was this idea of how could we work together. And so there is this program which has been around for a long time that we call Breathe Easy. And this was, we were able to take advantage of the internet and being able for groups to be able to communicate with each other. So if somebody was sick and they were in the emergency room, and it could have been at a health center, could have been at a hospital, but by asking a few questions about their housing conditions, finding out that yes, they might have had mold or they might have had some pest issues, that they could make a referral to the folks who are responsible in our community for doing the code enforcement. So in Boston, it's the Inspectional Services Department. So ISD would get flagged that somebody was sick and that there were housing conditions that were in play. So they would send a housing code inspector out that would visit that apartment. Boston Housing Authority being one of the largest landlord in the city of Boston, some of those apartments were ours. And, sort of just the backstory too was that if BHA was slow to address those housing conditions, or if things were ending up in court, it was not yielding a good outcome. It was taking time, and things were ending up in court. So by creating this program, Breathe Easy, where health providers, landlords, property owners, inspectional services could work together, we were actually able to, much faster to improve housing conditions for people that were sick and improve their health and quality of life. So Breathe Easy is something that I actually almost wonder how many other communities have adopted a model like that. But this is something that we've been doing for a long time. And if your community hasn't adopted it, they should be thinking about doing something like that. So that was sort of one example of how we started working with the Boston Medical Center. That led to a project that we called Project LEAP, the Living Environment Assessment Project. So this was, we had received a grant from HUD. We hired and trained some of our public housing residents to be place-based community health workers. They would knock on doors. They would visit people and give some asthma education. They would walk around their home and be able to identify some asthma triggers. We would provide some resources. Cleaning supplies, Tupperwares, give them some, pest monitors, help to work with the property managers in terms of work orders that might be needed in those apartments. And what we learned was that we were able to lower the number of asthma triggers in somebody's home. So that's another example. That led to something that we called stocking the housing pharmacy. You always come up with some of these creative names when you're writing the grants. But so stocking the housing pharmacy, and this one is active, and it's through a local foundation, the Boston Foundation, and it includes Boston Medical Center and the BHA, but it also includes others. And the whole premise behind it is, are there things that we can do to help improve housing stability and to reduce healthcare costs for people who are medically complex? And it started off as something that we were doing looking at kids who were like 0 to 4 who were coming into the emergency room multiple times within a year and asking a couple of these triage questions similar to what we did with the Breathe Easy to find out if housing conditions were, if they were unstable, if they were behind on the rent, or if they were couch surfing, or if they were homeless. And so we were then able to link them, and we have these other partners, in this case, in terms of stocking the housing pharmacy. So we have somebody who's helping us with legal issues. There's somebody who's helping us who's teaching just like problem solving skills, so that that could be applied in any number of arenas. But so working with those people, we have case managers who are providing case management to those folks. And it's in this case, not everybody is going to end up in a BHA apartment. We might just be doing housing stabilization right where they are. But if they get evicted or something, then we have set aside some units so that people can come and be in the BHA. So that's another example where there are external partners and some external funds. But this has also led to sort of these two most recent examples that are current and ongoing. And these are just from resources from within the Boston Medical Center or within the BHA. One of them we're calling the Reasonable Accommodation Rehabilitation Fund. So funds from the Boston Medical Center are coming to the BHA, and we're going to be targeting those funds specifically at the elderly and the disabled who are facing some challenges in their apartment, and we can make some improvements so that they can be safer, healthier, and age in place. And so that's something that we're doing right now. And then we're also pursuing this other model. I'm currently, we're reviewing job descriptions, and we'll be hiring someone that essentially will be sort of like a BMC staff person who will be a navigator and who will be very involved in the BHA universe, so that when we have residents who are having a hard time accessing services, that we have someone on the inside at the BMC who's going to help us to sort of get our people connected with services. So again, I don't think any of those are necessarily like you've never heard of those ideas before, but those are all examples of how a housing authority and a hospital can work together, and that's sort of what I wanted to bring to the table. So I'll stop right there.
Yeah, so now we have plenty of time.
We have lots of time.
So please.
Yeah, please, bring on.
My name is John Sorensen. I work with CMS. I'm a project officer for the Massachusetts Money Follows the Person program. I was hoping you could talk a little bit about your relationship with them, because they've done some really great work with their MFP program. It's grown quite a bit over the last few years, and the housing piece has really helped that program a lot.
All right, so this is where I sometimes joke. I'm a pediatrician, and so I will admit this has been a new world for me to follow some of the, thank you. I'll crack the joke again. I'm a pediatrician, and I know just enough knowledge to be dangerous of the Money Follows the Person program. I would be curious about BHA's kind of experience with it, but this is, it's funny, I'm more familiar with actually the Money Follows the Person in California than I am in Massachusetts, which is its own hilarious idea. But it's the idea, I think more and more the idea of functionally marrying what I call a housing dollar with the kind of healthcare dollar that can provide all the wraparound services is exactly what we're trying to replicate right now. And so that being able to understand all of the potential dollars that could be brought to bear. So Money Follows the Person is one example. One of the things that if I have my way, we will have health plan care management deployed geographically instead of in offices in actual like health plan offices. Just so you know, I have started to dig into the data internally to my hospital, which is its own beast, around who are our highest cost patients and what address do they live at. And so Gail and John and I were looking at the addresses, and the first four are all homeless addresses, right? So like Pine Street, Southampton, right? But yeah, exactly right.
Homeless shelters.
We need an address, right? When you show up, we need an address, and without an address, guess what we use? We use your homeless shelter as your home address, or we'll use BMC as an address, or, but anyway, the top four are those. But then if you look down to the next 10, like 6 of the 10 are BHA properties. And so, and so there, there's, patients there that are using $100,000 a year of care, according to our records, and that's just hospital charges. That doesn't even include other charges. And so this idea, I will say, if we're talking about waves of the future, data matching is actually a huge need, and being able to figure out those data sharing agreements is an enormous, if we can get some ability to support figuring that out, and both, I think, our analytic capacity to be able to start to target geographically instead of by person, I think would be a huge leap forward for the field.
So I'd like to talk with you
I want to talk to you
afterwards.
too. Yeah, I want your
because
card.
I want, so you can tell me more about it. My only, I hear about this when I'm working with with homeless advocates and organizations that are working with the homeless and trying to get services. So, because we have a growing profile in that area. So I'd like to know more about it, because if we can get more, I'd love it.
John, do you have any?
Nope, I'm gonna.
So, my name is Damon Daly. I work with Purpose-Built Communities. So I guess one of my questions is, so right now one of the, I guess, opportunities of trying to really maximize is getting some of these health institutions to be able to think about how they can strategically invest within a particular neighborhood, whether that be in housing or in education or in some other community wellness investment. So I'm curious to understand, or I'm curious to hear, what are some of the more persuasive arguments? Like, what is the case that we would want and need to make to a health institution? And who is the person that we need to be making that case to when we're trying to help them think about how strategically invest in their neighborhood?
Yeah, no, thank you so much for that. And this will be an interesting exercise where I'll be like, yeah, I want your card also, because purpose-built communities are really interesting in how they're kind of putting together the packages. I would say that, all right, so how many people have heard the term anchor institution? All right, so a lot. Okay, so anchor institution to me, we at Boston Medical Center are part of a healthcare anchor network, which is kind of administered by the Democracy Collaborative, and we have really liked it because they kind of have simplified it down into, we as an anchor institution are using our economic power to address inequities. And we're doing that through three ways. We're doing it through investments, through hiring, and through purchasing. And so that has helped us as Boston Medical Center to internally organize ourselves around a community hiring initiative, right? Starting to do more local purchasing, starting to, I think our housing investments is our first foray into investing. But one of the things that was interesting for us was when we were going around to housing agencies and being like, hey, if we had money, what's your pain point? What thing would you want from us? One of the answers we got was, oh, we're building this really, Nuestra Comunidad, a community development corporation, building this really beautiful mixed income, mixed use place, had a first floor retail where they thought they were gonna have an affordable housing market. That market pulled out. We're going to potentially have vacant first floor retail, which is going to completely mess up their kind of financing stack. And so they said, could you help us attract a really good food market, and almost like a not-for-profit food market that was going to be able to do it? And so we said, yeah. And so we're actually going to do a no-interest loan, like $1 million no-interest loan, and provide operating subsidy for a couple of years as a way to get this kind of market off the ground, which is going to locally hire, locally purchase, and become, we think, a social networking place for the community, right? And so I do think that there are ways to make the investment argument where you're basically looking for a community health payoff, a community health return. And I think there are ways in which you could make arguments that you could tap into that community benefit dollar and or the investment dollar with a community benefit purpose as a way to kind of get there. What I have tried to argue is what will completely get you over the finish line, though, is if you can bake in any population health payoff. That middle group of dollars that I talked about. I actually wrote a JAMA viewpoint on this, that hospitals should invest in housing to improve mission and margin. So the community health improvement is a mission-related investment for us, right? Like, we're not gonna make that much money. We shouldn't make money off of it. We should plow that investments back into the community. But because we're feeling so much pressure on these value-based payments and people who are high cost, high need, what we're asking our housing partners in Boston to do is to work with us to see if this new, say, housing development where we're subsidizing the market on the first floor, they have 12 extremely low-income housing units. Can we morph their tenant selection plan so that 4 of those could go to our high cost, high need patients? Now that is a leap forward. I am going to say that we're going to hoe that ground to see if we can like make that work. And that is, I'm going to fully acknowledge that this room may have real feelings about that. And, there are fair housing implications and other things. Before I get angry questions about it, I will say I asked Raphael Bostic and Sean Donovan this question, right? Like I went straight to people who I think are really expert in this. And they did feel like we already have made an argument in the chronic homelessness world that there is a societal benefit to having some units set aside for a certain group of people and seeing that efficiency. And what I'll just tell you is that if we can figure out a small set aside for what I would think are not people that can qualify as chronically homeless, but people who are like medically complex and homeless or housing unstable, I think you'll unlock a lot of dollars. And you should unlock a lot of dollars. You should completely hold the healthcare sector, to bat on, just like ask for a lot for that. But I just want to open your mind to that, because if you can make the mission-related community health investment argument and have a little bit of the margin pain point for us, which is the high cost, high need populations, I think you'll get that across the finish line.
Maybe I also asked you the question of who in the hospital.
Yeah. Thanks. All right, so thanks, Becky. Yeah, sorry. So this is what I'll say is I know a lot of housers have been knocking on healthcare for a while and feeling like it's a really frustrating conversation. So what I'm going to just urge you is that just because you tried once and it didn't work, don't stop trying. And really try, when I lay out the $3 in a healthcare institution, there's one group of people that are typically running community benefit. There's one group of people that are running the hospital and thinking about how the payment systems are flowing. And there's one group of people that are running the investment portfolio of the hospital. And in almost every case, those three people don't know each other. They don't know their names. They never have met. They've never thought that there's a way of which that they can internally align their dollars. So just because you've talked to one group, keep talking to all of them. Like, talk to the treasurer CFO, talk to the people who are running the health plan or other things, talk to the people who are running community benefit. Like, just keep pushing all the different points that you can try to get into a hospital, because once you're internal it, you may be able to then get across silos, but just realize that we have our own silos in it, and not everyone can get everyone to kind of be on the same page. But I tend to try and think of the world as, just as I laid out the $3, there are 3 pillars in those hospitals that you could potentially go and talk to.
And so use all the people that you've been meeting all around your community, because you're going to go around and try and meet with and get connected to as many people as possible. So you should use those people too, because somebody knows somebody, and that that's how it works. And hospitals are worse bureaucracies than housing authorities. People think that housing authorities are terrible. Because we're super unbureaucratic in Boston.
Jennifer Thomas with the Housing Authority City of LA, Los Angeles. So in our case, there's not one hospital, there's several, multiple. Then we have FQHCs that are in abundance. We're the second largest everything in LA. So our strategy is more around kind of tapping into the Wellness Foundation to then engage those partners, but we're finding that the foundation community is just as ignorant as we are as housers and not really understanding the issues. So I guess my question is, how do we frame the issue in a way that we can have a third party advocate on our behalf? Because clearly we don't have the capacity to meet with every single.
Yeah.
I mean, public health is at the table, they get it. It's just a blessing because they're able to really translate a lot of the information that we're asking. But we're finding a lot of our work is educating kind of the foundation community on what it is that we're asking for.
Yeah, I think if people can hear the question, I think it's true. Like in every given community, we say healthcare, but that means a big, wide world of different types of institutions. So let me try to break it down. So the people you're the most aligned with as public housing authorities are the federally qualified health centers, right? Like you're serving the same people. They are, mission aligned, culturally aligned. The problem is they have the least amount of money, right? So they are the, I think they're great as partners. I actually do think there are ways in which to start to think about ways to work together with them. Like I've had kind of dreams of like housing allocations that flow through, like giving you additional monies or something like that of which to partner or work. And there definitely have been movements like Corporation for Supportive Housing has a TA contract with HRSA to support FQHCs in their working with housers. I think the next level up is what I would call the safety net hospitals. These are the hospitals that are either public hospitals or kind of public hospital lookalike. So Boston Medical Center used to be Boston City Hospital, and then it merged with Boston University Medical Center about 20 years ago. And so we are a not-for-profit private hospital, but we've kind of maintained our public hospital mission. If you want to look on our trade group is actually America's Essential Hospitals. So if you want to kind of look on their website and be like, who's my America's Essential Hospitals that in our neighborhood. The good news of that, again, is it's going to be mission aligned. We're going to serve the same patient populations. We have a little bit more money. We have money, don't get me wrong, but we are not the like huge academic teaching hospital private big engine in your community. So the next level up is the UCLAs, the USCs, the people who have a lot of money. The question is whether you can find people in there that are mission aligned, and I think you can. Where I think I don't think it's really a secret, but I don't know why people don't talk more about it, is that there is this subset of patients that are either in your housing or should be in your housing that are complete pain points to these hospitals, right? Like these are the people that every resident who trains at the academic medical center knows by name. They, like Mr. Smith comes in every month. Every resident has taken care of Mr. Smith. When Mr. Smith walks into the ED, the nurses are like, "Oh, Mr. Smith, it's so nice to see you again." Like, and so there's and the thing is that person has healthcare costs, but they also occupy a bed that could be used to serve someone else. And so there's like many system savings in that. So like when I was trying to sell this to our chief strategy officer, our housing initiative, and I was like, well, like, I kind of misunderstood and was like, we have huge readmission risk with these populations. So they leave the hospital, and the complex homeless populations, within 30 days, they're coming back to be readmitted 70% of the time. 70% of the time. And so I was like, listen, we got to do a housing initiative. We can try and reduce that. And then he was like, whoa. Are you telling me that we're holding on to people in the hospital that are homeless to see if we can figure out a place for them for an extra day or two before we, eventually kind of, frankly, aren't able to find them a place? And I was like, yeah, like on average, your homeless patient with the same diagnosis is staying an extra day or two in the hospital. He was like, oh, you've already sold me on length of stay. Length of stay, right? Because when you discharge, we don't get paid per day. We get paid per diagnosis. So once you come in, you have a diagnosis, we get a lump sum of money, we discharge you, and then we can turn the bed over and get another new chunk of money for that diagnosis. And so while we are in this value system, don't get me wrong, like we don't want to hospitalize people anymore because we may not get paid. The issue is that we don't want to be building more towers, right? We want to use the beds we have more efficiently. We don't want to pay more nurses and more doctors. We want to be able to do that. And so the ability to not have someone clogging a bed is a real selling point. And so, but again, this is where the healthcare world right now is waking up to the social determinants of health, right? That's what we're now using. That's the term of art you should use with us. You understand the social determinants of health. Everyone, the good news of that is we understand social determinants matter. We understand that housing is probably the most important social determinant. But here's the problem. The next sentence healthcare will say is, well, we can't do anything about housing. You guys can do stuff about housing. You just have to be able to present yourself as having a solution. And that's where, again, this kind of preferred access, like how were we able to do the housing prescriptions program that John referenced was BHA has a supportive housing waiver, and they were able to say, shut the phone off, or no, you shut the but
No, I mean,
yes. Yeah.
as part of our oops, that's fine. As part of our admissions and continuing occupancy policy for public housing, we have a provision that says from time to time the Boston Housing Authority will enter into agreements with, I don't know who, anybody, I mean, no, and, to provide supported housing, programs. So we have a bunch of little programs. We have Healthy Start in Housing, which is for homeless or housing insecure pregnant women. And so we give them a place to live. They get case management from the Boston Public Health Commission for this program for years. We have our chronically homeless elders. We have, we work with people coming out of shelters who run to the top of the list. Above all the other homeless people, we have the program for these medically complex elders. We just have a bunch of those kinds of things, and that's what we do. And every once in a while, people will say, "How can you do that?" And then I'll say, "Oh, we do it. It's in our ACOP. It gets approved by HUD every year. At our annual plan, whenever we change it, the fair housing people look at it, and it's like, so we just keep doing it. And that would be really tough for people to come back and say. Plus, we're housing the most needy, most vulnerable people through these programs. So what advocate wants to come in and say, this is terrible, stop it, So, but we do, and so we do. We create these programs, and we have bunches of them. It's if you can figure out how to do this or get, it's really to our advantage, because what happens with these programs is we have medical organizations or other who are providing, who are on the hook for providing supportive services for these folks when we house them. Now, we have a priority for homeless people. I mean, so most of the people that we house are, either street homeless or shelter homeless. And so it's not really a different population. So it's to our advantage to the extent that we can have people coming in with services, with case management. It makes it easier for the managers. They throw less things at me when we have our managers meetings. And it just works better because it helps stabilize people. It's better for their other residents, and it keeps people successfully housed, which is actually what we're all about doing. So, yeah. So call me, I'll send you my MOUs.
So I'm Gail with CSH, and thank you for making the mention of our HRSA PA. But we also mentioned at an earlier session, and I refer back to your question about money follows the person and resources, making sure everybody is aware of the two recent NOFAs that serve vulnerable populations. So there's mainstream vouchers and the family unification program. So that's something that you as housing authorities can go access those new resources and then bring it to the table for your potential partnerships. And the NOFA does require that you're building these partnerships.
Yeah, and I think that that's one of the things I was thinking about when I mentioned it makes it easier to jump on funding opportunities. So we see that and we're like, oh, this is great, and we can talk to Megan, we can talk to the Public Health Commission, we can talk to some of the homeless advocacy groups that we've been working with over time. So we've got a bunch of built-in partners, and so it puts us in a great position to really craft a quality program.
Yeah. You mentioned the ACOP. Do you do any tracking with Section 8?
What do you mean exactly?
Well, as far as any of your resident or any of your voucher holders having medical issues?
No, not really. And that's like a whole I really want to do that. I want to figure out how to do that better. And I want to figure out how to do a whole lot of things better with that population. Well, no, I mean seriously, because I started out just on the public housing side, so I'm like, I love my units. I have the residents. They're my residents. They're not my participants, and so it's a whole different mindset. But we're still giving them this super valuable resource, and we need to help the most vulnerable, and they're, extremely low income, and, the folks that we house who are the voucher holders also, and they don't get supports in the same way. And so that's an internal issue as well as like trying to find people outside to help, because the folks who run that program have a different mindset. But anyway, yeah, no, we don't, and I'd like to.
Good. All right, I think we can do one last question, and then we'll stay, obviously, afterwards. All right, Steve.
Have you all had any experience with using social impact bonds to fund innovations?
So it's interesting. So Massachusetts did do a social impact bond, and it actually is a successful bond. It just paid off its first installment. And this was what was interesting. I was not directly involved in it, so I'm going to tell you my understanding of it. I'm hoping it's right, and then I can connect you with the people who really ran it. Was the intermediary was United Way, and I believe CSH also provided technical assistance for it. And so you can go talk to the CSH people, and feel free to correct me when I say something incorrect, is that what was, I think, the most beautiful part of the social impact bond is it paid off of a single measure, which was you house someone for 12 months contiguously. You didn't have to prove that you saved money. You didn't have to prove that you had done a certain thing. You just got someone off the streets into housing, and they stayed there for a full year. And by making it really simple, and there was a whole kind of configuration of different housing providers and others that participated, I think that made it easier to be successful. I think the other piece of it was that it was under Governor Deval Patrick's administration, where they were able to pull off the money and have it functionally sit in an account, so that they were able to really carry the money over, and so there wasn't kind of as much of a would government pay off, which is typically the biggest problem in social impact bond, is who's going to pay off at the end. And then they had a bank that was actually willing to put their neck out. Santander was an investor in it. And so I do think I don't love social impact bonds, and the reason is that typically their impact that then the dollars, the profits out of it go out of the system, and I'd rather they go back in. But sometimes that is a way to get towards proof of concept. I don't know if the CSH people have any comment on it.
Just two things. So the intermediary is actually the Massachusetts Homeless and Shelter.
Oh, sorry, Bahasa. Thank you.
And the United Way is a partner as they have the fiduciaries.
Got it. Thank you.
And then there are several investors, including CSH, who are invested along with Santander and the United Way. And there's a shared governance structure.
So if cost savings weren't documented, how was it paid back? Because I thought it had to be paid back from the cost savings.
No, not always. And so the housing stability is the metric, is the benchmark for payback.
Yeah. So that was the huge part, right? Was that they set aside a pot of money to pay it off, and then they defined the metric, and they kind of trusted that metric would lead to cost savings, right? So it was not structured the way the normal social impact bonds are, where you have to document the savings to then go through it. And I think that is an interesting, it makes it kind of almost like an investment pool, where you were able to put it off in a separate place. But
Thank you, our mentor,